Hi everyone, welcome to another fertility Q&A series with the expert. And our expert today is Dr. Jie Deng. She did an awesome job talking to us about the risks of IVF. If you haven't watched that show, you should definitely be tuning into it. It's a very, very thorough analysis of the risks of IVF. And here she is. I'm so excited to have her on right now. Her pages and pages and questions. You guys did a great job sending them in. I'm so excited I can barely talk. Hi, Jie, how are you? It's nice to see you.
Dr. Amy, how are you?
I'm doing great. So for our audience, can you just tell us about your practice? Tell us a little bit about you, and then we're going to go right into our questions.
Okay, all right. Hi, everyone. I'm Dr. Jie Deng. I'm a reproductive endocrinology and infertility fellow at Stanford. I had my medical degrees in China. I was fully trained as a fertility specialist and practiced for a couple of years in China before I came to the US. And after I came to the US, I had additional training. I completed my OBGYN residency. And afterwards, I went to Yale. I had my maternal fetal medicine fellowship and worked as attending at Yale for a couple of years. I came to Stanford 2 years ago, and now here I am.
Awesome. Well, it's so great to have you here. We're so lucky to have you in the Bay Area, and I can't wait for all the amazing things that you're going to do to improve women's health and especially fertility. Okay, here we go. I'm going to start asking you questions. Hello, doctors. Thank you so much for doing this today. They're so helpful. My question is this. I have PCOS, but definitely ovulate. My follicular phase is just very long, sometimes up to 25 days. Every month, without question, I get sore breasts 7 days before my period like clockwork, and I have trouble sleeping before my period arrives. Would this also happen once I'm pregnant? I feel like this month, or I should say, I feel like each month this happens, and I just count myself out for that month. I'm 32, trying to conceive for a few years with one miscarriage and one chemical pregnancy. I've thought about IVF, but I'm terrified of all the risks, meds, shots, side effects, and surgery. What advice do you have?
Okay. All right. So there are several questions. But like, first of all, for the breast, tenderness, it's not uncommon for women to have some premenstrual breast, like swelling and tenderness. Sometimes it can happen during early pregnancy, especially in the first trimester. But most people, their symptoms can improve over time. And I would say if your a tenderness is significantly impact your quality of life, you probably want to be checked with your OB/GYN doctor. Just make sure there's no lump or any a fibrocystic disease of your breast that can cause significant pain. Otherwise, use some a supportive bra or use some ice pack or warm compresses, whatever you feel like it's going to help you. And in terms of your PCOS, sounds like you had one miscarriage and one biochemical. I would say if you have been trying to get pregnant for a couple of years, it doesn't hurt to go and see a fertility specialist. Seeing a specialist, a doctor, doesn't mean that you need to jump into the IVF right away. But it's always good to make sure you don't have any other etiology. For example, any uterine factors can potentially cause pregnancy loss. So that's what I would recommend.
Absolutely. Get a full workup, see what's going on. Just because you see one of us doesn't mean you have to jump.
Exactly.
We're not going to force you to do IVF. We're just going to teach you about your body.
Yeah,
okay,
right.
Here's another question, also PCOS related. I'm 31 years old, trying to conceive for 2 years. I have mild PCOS, a high follicle count on longer periods, anywhere from 31 to 41 days. I'm terrified of having a miscarriage because I already had a miscarriage that unfortunately was it was a genetic abnormality of the pregnancy at 14 weeks that I had to terminate. Do you have any advice for me?
First of all, I'm so sorry that for your pregnancy loss. The PCOS, I think one good thing about PCOS is you have a good number of follicles. The most important determining factor for fertility is a woman's age. So if you're age 32, right? It's how old
right.
are
you? This person asking this question is 31 years old.
Oh, okay. So I would say at 31, age 31, your chance to have a normal, genetically normal. When we say genetic, we mean chromosome, a number is normal, X, is probably about 80%. So you do have a good chance to get pregnant and have a natural pregnancy. Understand that your miscarriage at 14 weeks was absolutely like traumatic for you, but depends on what's the cause, especially if you had like a genetically abnormal embryos, then I think that explained why you had a miscarriage. But as I said, based on your age, in your next pregnancy, you still have a good chance to get a normal.
I agree. So someone's asking live here, but what about if she was 42 years old and not 31? What advice would you have?
That's like a very good question.
Yeah.
So at age 42, so the chance to have abnormal eggs is probably as high as 80%.
Right.
So that's a reason. And most of these like abnormal eggs would not end up with pregnancy. And even if you get pregnant with these abnormal eggs, there's a high chance that you might go to miscarriage. That's the reason. As we, like women, get older, then it's hard to get pregnant and easy to have miscarriage. So I would say at age 42, if you can get pregnant naturally, that's the best thing for you. You can still try, although the chance of having miscarriage is high. But if you say, I truly want to do everything I can to avoid a miscarriage, then potentially the pre-implantation genetic testing, that's a technology that can help you. But you have to go through the IVF though.
Okay, here's another question. I'm 35, almost 36 years old. I've been trying to get pregnant for 6 months now. I have regular periods. What should my next steps be? Should I go to my fertility doctor or a fertility doctor? Should I go to my gynecologist? At what point should I do IUI? How long does it take before I'm even able to do an IUI if I decide today?
Okay, that's a good question. Actually, so there's a recommendation from American Society of Reproductive Medicine. If you're age 35 or like beyond age 35, if you have been trying to get pregnant for 6 months and hasn't been successfully, get pregnant, then we recommend that you go and see a fertility specialist to get evaluation and assessment. And the next question is, about IUI? Okay.
Yeah, about IUI. At what point should I consider IUI? And if I decide today, how long will it take until I can get my first IUI too?
Okay, yeah, sure.
Yeah.
So when you go to see a fertility doctor, usually they will do several evaluations, including your ovarian reserve, your fallopian tube, and the semen analysis. And based on these results, then you will go to several treatment options. IUI is usually offered to patients who has open tubes, first of all, and with normal semen parameters. And if everything looks normal, I think IUI is the most probably cost-effective way to start with. And it depends on which day are you in your cycle when you see the fertility doctor. Typically, IUI, we start to give several pills starting on your cycle day 3 to day 5, and then you take for 5 days. We then ask you to come back to monitor your follicle size. If you happen to be at the beginning of your cycle, you're ready to go. If you already passed your ovulation in this cycle, then you have to wait until your next menses.
Right. Okay, here's another question being asked live. I have one question that I ask Dr. Amy every month. What's the natural chance of pregnancy for a 45-year-old?
Oh, okay. Depends on if you're planning to use your own eggs or if you plan to use a donor egg. I would say for most women who's age 45, the chance to get pregnant by using their own egg is probably in single digits. We never say 0, but it's definitely less than 10%, probably less than 5%. But we do see women get pregnant by using their own eggs at age 45. It's just that chance is low. Right. By using donor eggs, then that's completely different story.
Right. Yeah, good answer. Okay. Here's the next question. You do the best Q&As. This time I'd like to ask this. I did my first IUI. I used letrozole, 2.5 milligrams, only one follicle grew. I triggered on day 23 of the cycle, and I had an IUI on day 25. Are my chances super low because there was only one follicle? I'm on day 8 trying, in the 2-week wait, and my doctor used 10,000 units of Novarol sub-Q. Any idea why Novarol when my other friends use Ovidrol?
Okay. All right. So these are great questions, first of all. Typically, the successful rate of IUI cycle, we say like each cycle is about 10%. There are several other factors can affect your chance. For example, women's age, how many follicles do you have, and what's the endometrial lining thickness. Yes, having 2 or 3 follicles will definitely give you higher chance compared with having only 1 follicle, but doesn't mean that you cannot get pregnant with 1 follicle. But theoretically, you only need 1 normal egg to get pregnant. Hopefully this cycle will work, but if it doesn't, then I think like your doctor can increase the letrozole dose. For example, give you 5 milligram a day for 5 days in your next cycle. And I'm sorry, what's the next question?
I know, Shanda? We're getting so many questions. The other part of the question is the difference between Novarol and Ovidrol.
Oh, okay. So there are 2 technology platforms to produce HCG. Both of these medications are HCG. In terms of the effect or efficacy to induce ovulation and egg maturation, they are the same. I don't see the difference. It's just one was produced from postmenopausal women's urine, and Ovidrol was produced by a genetic recombinant technology. I think doctors have their own preference to use one medication versus the other. Sometimes your insurance policy might determine which one they cover, which one they don't. So, but they're pretty much the same.
Yeah, exactly. Okay. Hello, doctors. Thank you for the good work that you do. I want to ask Dr. G, which method of FET does she prefer, natural or medicated, and why?
Okay, this is a really good question. So first of all, for people who does not have a regular menses, which means if they don't ovulate spontaneously, then they are a good candidate for a medicated cycle. If a woman has a regular cycle, which indicates that she has a spontaneous ovulation, then she can go either way. So natural cycle FET, you need to come back to the clinic more often because we need to monitor your follicle size, and also you might get several times of blood drawn to check your hormone levels. And for medicated cycle, you just start the estrogen from the beginning of your cycle for 12 or 14 days, and then we check your lining thickness. If it's good enough, then we add the progesterone. So medicated cycle definitely is easier to control and more convenient for doctors and patients. That's the reason many IVF centers and the doctors, they prefer medicated cycle. In terms of the outcome, actually these 2 modalities, they have similar or a comparable live birth rate. So there's no recommendation support one versus the other. So I think both of them are okay. It just depends on your situation.
So the same person asked, also, I had 1 failed FET with a genetically normal embryo, and I previously wanted to do the ERA test for my next transfer, but now I've changed my mind. Now I want to do an FET using a natural cycle without the ERA. What do you think about that?
Okay, so I think if you sounds like you probably had a medicated cycle with your first transfer. If you failed that transfer, you want to try natural cycle, you have a regular menses, I think it's completely okay to try different things. ERA, you don't have to do it if you don't want to. And also the data for ERA, original data for ERA actually came from medicated cycle as well. So now some doctors are doing ERA for natural cycle, but no matter what, if you decide to go back to do ERA, in your real embryo transfer cycle, you want to have the exact protocol as what you had with your ERA.
Perfect. Thank you. Okay, another question. Also, a friend had a successful transfer of genetically normal embryos. She did the blood test that comes with an anatomical scan, and they said that she's high risk for trisomy 18. Should she be worried? She's 36 years old. So genetically normal embryo, then did the NIPT with positive for trisomy 18.
Okay. I'm sorry, your friend must be super stressed by this result.
Yes.
But a pre-implantation genetic testing, I think the false negative rate based on data, is very low. It's not zero, but I think it's about 1% around ish. Correct me, Dr. Amy, if
I
I'm wrong.
agree. Yeah, I
Yeah,
probably see one yeah, I mean, yes, you're right. I agree.
probably around that,
Yeah,
less than 5%, I would
right.
say. So for NIPT, there's NIPT is very good if you get negative result, which means like if you get negative non-invasive prenatal diagnosis, then the chance you have abnormal fetus is low. However,
Right.
NIPT has false positive rate.
Right.
So I would say trisomy 18, if she goes to the ultrasound, I think anatomy scan is important. If it's a real trisomy 18 baby, you would definitely see some congenital anomalies. And I think amniocentesis will be recommended to confirm the diagnosis.
Totally. And what I do sometimes is I use a different company for the NIPT. And a week later, I get a result and it's normal. And I say, see,
we have the technology has its limitations.
Yeah, definitely. Okay, here's another question. Can you talk about HGH, or human-derived growth hormone, in detail and the role for improving eggs and sperm quality, and what dose do you generally recommend?
Okay, so growth hormone is produced by the pituitary, basically our brain. There's growth hormone like receptors on the ovary around the follicles. So growth hormone has been used or has been shown to improve the follicle development in mouse model, in animal models. Yeah. In human being, that data is a little bit mixed. But there like a data there show like using growth hormone can, especially in poor ovarian response women, it can help and decrease the duration of stimulation, lower the medication dosage, and increase the number of follicles or eggs. And some reports say it improved the live birth rate. Some say like there's no significant difference. So I think the data is still debatable. But for poor ovarian response patients, sometimes I feel as a physician, the treatment options we can offer to the patient are limited. Right. And if a patient is willing to try, this medication is safe. It's not, it's a little bit expensive, but I think it's worth to try if you're willing to do it. Right. It can potentially help you.
Yeah. I bet there's something in our DNA, it's like a certain genotype that it helps, because I certainly find it helps some patients and it's phenomenal.
True, very
and other
true.
patients it doesn't. And I just wish that I knew what the differences were, because then if that person, I knew it wouldn't help them, then they wouldn't have to spend all that extra money on the drug.
I 100% agree with you.
Yeah. Okay, cool. Here we go. What is your favorite prenatal vitamin?
Oh, okay. I don't have a specific brand. When I was looking for prenatal vitamins, I checked for several key nutrients, which are important for reproductive health. For example, folic acid, iron, vitamin D, calcium, iodine, DHA. Those are things I want to see on the label. And for the folic acid, you want to see a 400 to 600 microgram. You want to take those in a day. And vitamin D, I think a recommended dose is 600 international units a day. Most prenatal vitamins, they contain 400 international units. You can make up that difference by drinking milk with fortified vitamin D.
Perfect. And what about the right amount of fish oil or DHA?
Fish oil, yeah, that's a good question. So fish oil basically contains DHA and EPA. Right. So recommended dose for DHA is 300 milligram per day. So when you go and buy the fish oil, sometimes they show 500 milligram or 1,000 milligram per capsule. It doesn't mean that they contain the same amount of DHA plus EPA. So you want to check on the label to see what's the exact amount of those true bioactive ingredients they have.
So there's a live question that just came up, and it was very similar to one recent previous question, so I want to ask it to you now. Is a false positive for trisomy 21 common for the state test? Okay, so I think that's the triple marker test, the serum screen, the quad screen.
Okay.
You know what I'm saying?
Sure.
And can the anatomy scan detect or confirm the three most common trisomies? That's the question.
That's actually an excellent question. So I think a false positive rate of NIPT depends on maternal age a lot of time. And also, for example, if a woman is young, then she gets like a positive trisomy 21, then the chance to have a real one is relatively lower. And also depends on anatomy scan. If there's any congenital anomaly appreciated on the ultrasound, definitely that increases the risk of real, like a chromosome abnormal baby. For Down syndrome, trisomy 21 specifically, there's some percentage of a fetus will show completely normal on ultrasound. But if the ultrasound is normal, then the chance to have a real Down syndrome baby actually dropped significantly to only like 15 to 20%.
Perfect.
I think.
So I have a live question here. At what stage, this is related to acne medication and IVF, at what stage, and this is Dr. Heidi Goodarzi, she's a dermatologist in Newport Beach. At what stage of IVF do women have to stop their acne medication? 30 days before retrieval, good? We stop 30 days before they try in natural pregnancy. And I think what she's talking about is like spironolactone, for example. What do you tell your patients?
I would definitely say, well, I think like I would recommend probably the same, like 1 month before the retrieval. Because like basically the organ formation critical stage is like before 18 weeks, but like early, sometimes the organ development like early as like 5 weeks is or so, like a critical stage. So I would.
Perfect. Okay, so here's an IVF question. I ended up with a day 3 single embryo. It was 4 cells, grade A, slow growing. The doctor was very pessimistic. Are you also pessimistic? What do you think? That's the question.
Okay, so I think on day 3, most good potential embryos will have 6 to 8 cells. But it doesn't mean that a 4-cell embryo will not make you pregnant. I do see women get pregnant after transferring 1 day 3 4-cell embryos. Yes, so a day 8-cell embryo has better potential than 4-cell embryo, but it's the chance to get pregnant with a 4-cell embryo is lower, but it's not rare. I would say it's probably roughly around like a 6 to 8%. Depends on which data you look for. But you know what? You never know. There's always hope. So I would say I'm crossing my fingers for you and hope for the best.
My fingers, toes, and nose. And that makes people wonder, like, how do you cross your nose? I have a big nose, so it takes on a personality of its own. Okay, here's another question. What is the ideal AMH level for a successful IVF cycle? And thank you so much.
Okay. AMH is produced by small follicles on the ovary. AMH level can tell you, can predict like what's your response will be during the IVF treatment, how many follicle or eggs you can get. But it does not tell you what's your egg quality, because the most important factor is still maternal age. So I would say if you have a good, have a normal AMH level, 1 to 4, that's good. But if you have low AMH level, less than 1, it doesn't mean that you cannot get pregnant. A young woman with low AMH still has a fair good chance to get pregnant. I would never say like you cannot. I mean, AMH level should not like a limit.
Right.
Yeah.
You're not a number. You're not your AMH.
Exactly.
What drives me crazy is that there's so much messaging that's just not right out there. Let's say a 35-year-old with an AMH of 0.2, and then she thinks she has the eggs of a 45-year-old, and she's been told that, and it's just not true. She still has a chance for pregnancy.
Exactly. Yeah.
Okay. So I have a very long question, but before I get to that one, I'm going to read this one here. I'm 26 years old, and I was admitted in the hospital 4 years ago for PID. For those of you who don't know what that is, it's pelvic inflammatory disease. Can I still have babies? What does this mean? What should I do? How do I fix it? If I can't have babies, please help me. Give me some advice.
Okay. So I think like you like brought up like a very good questions, and your concern is very reasonable. First of all, PID is associated with some tubal factor infertility because inflammation sometimes can cause adhesions in the pelvis. And also it's associated with higher chance of ectopic pregnancy. But I would say if you haven't been trying to get pregnant, or if you don't plan to get pregnant right now, you don't have to be like worrying too much. That's what I say. Overall, the chance to have infertility after one episode of PID is roughly about 6 or 7%. It's higher than general population, but it doesn't mean that you cannot get pregnant naturally after
You mean I can't scare young people out of like, just, you can't do that and have unprotected sex, or else you'll never be able to get, I can't do that anymore? It's only 6 to 7%. Okay, fine. I will stop. Okay.
Well, I mean, it's always good to like as what she said, have protected sex, but I mean, like with one episode.
The reality is you shouldn't be that worried about it.
Exactly. Yeah. But if you get pregnant, you want to go to your doctor as early as possible to just make sure the pregnancy is located in the normal location. And if you actively tried to get pregnant for 6 or 8 or 12 months, you still cannot get pregnant, then it's very reasonable to get your tubal checked.
Right. Absolutely. I agree.
Your tubes.
Okay. This is a long question, and there's several parts to it that it was emailed to me for this live Q&A. So I'm going to start reading it. Hi. Thank you for doing this. You guys are awesome. I've been watching you and find the Q&As very helpful. So thank you. I'm 36 and I've recently been told that my AMH is now 0.7. It was 0.9 1 year ago. My partner's 28 years old. Go team, you're 36, he's 28. We love to hear that. And his sperm test revealed 3 out of 4 normal numbers. Volume, concentration, motility, all really good. The morphology was 0%. We'll be repeating his sperm test in 2 weeks. He drinks 4 cups per day of coffee. He's going to cut back and entirely on alcohol in case that helps. We would like to have 2 children, but we're now concerned that we may not even be able to have 1. My fertility doctor said this. They told me, are you ready for this? Poor woman. That I have the numbers that are above a woman who is 36 years old, that I have the numbers of a 40-year-old woman. Does that sound correct? That's part 1 of the question.
Well, I never told my patients, say, hey, with your AMH level, your egg or like your ovarian age is like the same as like an age like 42 or like, right. I never told them that. The AMH level can only tell you like how many follicles you have, but never be able to tell you like your egg quality. Your age is still most important factor. I'm so sorry that like you're having so much stress from like these numbers, but I would say with the AMH level 0.7 at age 36, you still have a fair chance to get pregnant. And sounds like you're doing whatever you can. You're taking supplements, and your partners are doing some like a lifestyle change, and you're actively like seeking fertility care. You're on the right track. In terms of the semen, I think like sounds like all the parameters are normal except the morphology. Morphology actually is a poor parameter to predict whether a man is fertile or infertile, especially if it's an isolated finding. I think it's very wise for him to repeat the semen analysis in 2 weeks. If the repeated semen parameter still shows like a 0% morphology, and I think he might want to be seen by a urologist, just to want to make sure there's no medical reasons that can impact the semen quality. For example, varicocele is like a very common reason that can actively impact the semen quality. But I think you guys are truly like doing whatever you can to try to improve your chance. I'm holding hopes on you guys, and I think like you're on the right track.
Awesome. Yeah, I agree with that. You know how I designed the Tushy method, right? And I don't know if you know, I also have the balls method for men. Balls is background genetics, anatomy, lifestyle, labs, and sex. So Look up
That's
ballsmethod.com. Okay. So that's
I
it
take
for
your
all.
I take your course one day to learn that.
Thank you. So that's it for the questions that were sent to us. So now are you ready for the questions that have been chatted here live?
Yeah, sure.
Okay.
Let's
Okay.
do it.
Someone said, haha, I was told my AMH, FSH, AFC was that of a 49-year-old. Well, I'm sorry you were told that. That's very mean. Not that, I mean, I'm almost 49, so I don't find that mean, is what I mean. Okay. But you know what I mean. Okay. I had my first follicle scan today on IVF treatment day 6. I have 28 follicles, and they're all between 5 to 11 millimeters in size. Okay? Treatment day 6, 28 follicles, 5 to 11 millimeters. Should I be worried about the big difference in the size, 5 to 11 on treatment day 6?
Well, so are we talking about the same like person who was told that
No,
like
this is a new person. No, this
new
is a
person? I'm
totally
so
new
sorry.
person. No.
Okay,
This is
I'm so
rapid
sorry.
fire. No, you're doing great.
Okay,
So this
got
is a
you.
new question.
So
Yeah.
on the treatment cycle day 5, you had like a follicle
5 or
numbers
6.
5 or 6 vary
Yeah.
from like 5 to 11 millimeter.
And
Actually,
28 follicles.
28 of, okay.
Yeah.
You know,
Yeah.
first of all, I think it's a good thing that you have so many follicles. The size varying between 5 to 11 or 12 millimeter actually is very common. Although we're giving the medication try to support the whole cohort of follicles, these follicles do not like grow at exactly same pace. But sounds like you have a very good number. I feel like sounds like you're responding to the medication and the treatment pretty well. As long as like a majority of your follicles are growing with a similar pace, I think you're going to have a good prognosis.
Yeah, I agree. Okay, here's another question. Does method of priming for IVF and duration help if I'm 40 with a low AMH and poor ovarian response history, and I'm priming with agestin and considering priming with birth control pills? Will either one of those priming methods help me?
Okay, so I think was like a priming with birth control sometimes for some women can suppress endogenous FSH level. And depends on how many days you're going to use them. If you use them like 12 to 2 weeks, some people might not show like get like so much suppression. But if you use that for like a long time, like 3 weeks or more, then I think it will negatively impact your response. And depends on your like a doctor's protocol they plan to use. I think it's good to bring up this question and just like talk to your physician about to say, hey, I'm concerned about this birth control pill use. Do you think like should I try something different or not?
I need a t-shirt or a bumper sticker that says I hate birth control pills because they're disgusting to me. I'm just kidding. But they confuse people because like we want to get pregnant and they're told to be on birth control. They should be called fertility planning FPPs, right?
FPP,
Fertility planning pills. Like we're not talking about birth control, but I agree. I think they can suck, especially if you're 40 or more with a low egg count. They can certainly suppress. But some clinics need to use it because they just have to for planning purposes.
Exactly.
Okay, here's another question. Are the success rates different as far as live birth between fresh and frozen transfers?
Okay, that's like a very good question. So I think it depends on patient's situation. We are not doing many fresh transferring nowadays because many women are choosing to have a pre-implantation genetic testing that requests freezing all the embryos. For fresh transfer, we look up several things. First of all, what's the estrogen level? If estrogen level is too high, for example, more than 3,000, then that will definitely negatively impact your chance of pregnancy. And also we look at your we also check your progesterone level on the day of trigger. If your progesterone level is higher, for example, higher than 1.5, then that means your endometrium receptive window might close sooner. So in that case, we would not transfer like a fresh embryo. But overall, I think there's a data suggesting that like a frozen embryo transfer has a higher live birth rate than the fresh embryo transfer in some specific population.
Right. I mean, I remember when we started doing more frozens, and I had to talk to people that frozens it might be better. And then it's funny how trends change and people ask these questions all over again. So here's another question. I was 34 years old at the time of my egg retrieval. 34. Okay. My history is ruptured ectopic, decreased ovarian reserve, and endometriosis. Only one embryo out of 5 made it to freeze on day 6, and it was graded 4BB. Okay, so a 34-year-old with 1 4BB embryo, ruptured ectopic, DOR, endometriosis. What is the percentage rate that embryo will have normal chromosomes? What would you predict?
At age 34, I would say it's probably roughly around 40% will be genetically abnormal, which means like 60%, 50 to 60% will be genetically normal. Cool. That's what I would
predict.
Predict.
Yeah. Okay. So here we go. I have a whole bunch of other questions right here, and people are commenting that just really cute comments, which are great. Okay. Let me go here. Okay. Would you include Femera while doing a natural frozen embryo transfer?
I'm sorry, include what?
Femera or letrozole.
Oh, letrozole during the natural
cycle. Yeah.
Well, I think if some people who has a PCOS and they don't want to use a medicated cycle, then letrozole can definitely help to stimulate the follicle growth. Yeah. And there's some data actually show like letrozole can help to increase the live birth rate, like a kind of a modified natural cycle. Personally, I am not using that much unless the patient truly has like ovulatory dysfunction. I like a natural cycle because I think if a follicle can grow naturally, then we can go with that.
And what about a trigger shot? Do you use a trigger shot even if you're not using letrozole when you're doing natural cycle?
We use a trigger shot for everyone. Yeah, exactly. I think that can help definitely.
Okay. Yeah. Okay. So here we go. I'm 35 years old. I have uterine didelphys. So that means having 2 cavities. And an embryo transfer is scheduled for the end of July. I just started acupuncture. Is there anything else I should do in addition to medication to prepare my uterine lining? What kind of advice do you have for someone with uterine didelphys planning a transfer?
Okay. I think for uterine didelphys, the decision to go to the transfer would depend on what's the size of each cavity. We want to transfer the embryo to the cavity with like a large or big volume. And also, like your doctors probably want to evaluate the endometrial lining thickness before your real embryo transfer. And I think a hysteroscopy to take a look at the uterine cavity can definitely help as well. Other than that, I think just kind of do usually what we would recommend for every woman, try to eat healthy, balanced diet and limit the caffeine or like alcohol and do like moderate amount of exercise. I think those things can help and take supplements.
Absolutely. Yeah. Okay, so now we have someone who's 45 asking about the chances of success using donor eggs and whether fresh is better than frozen for someone who's 45 using donor eggs.
You mean like a fresh egg versus like the frozen egg?
Correct.
Okay. Yeah. So I would say based on data, actually like a frozen eggs in nowadays, especially with those like a fasting vitrification technology, the outcome of a frozen egg is actually very close and similar to the fresh egg outcomes. Yeah. And it's just like a different, should we decide using the frozen egg versus fresh egg, sometimes based on how many children do you want to have. Right. Because with one batch of frozen like eggs, probably you'll get 1 or like 2, I would say like good embryos. But if you're using a fresh donor, typically we're talking about we can get like 20 or 30 eggs, and then those eggs can potentially produce more than 2 or 3 good embryos. So that's completely, I think it depends on how many children do you want and what's the financial resources like you would like to pay basically for those treatment.
Exactly, so there's options. So do you still have time? Because we have a whole bunch of other questions. I want to make sure we still have you for at least. Okay, cool.
I've been
Let's keep
enjoying
going.
this.
Okay, good. Here we go. This one's a good question for everyone to hear. And because of your background and experience, I love that this person asked this question. What are your recommendations around COVID for fertility and pregnant patients? Go.
Okay. Okay, good question. So I think for the COVID so far, the data did not show that the COVID viral infection can make a pregnant woman's health, let's say, let me draft it in a different way. Okay. So first of all, for most respiratory viral infection, pregnant women is actually a high-risk population because during the pregnancy, your immune system is trying to suppress those immune reactions, and that can potentially make your situation worse if you get infection. However, in the COVID-19 infection pandemic, we did not see that phenomenon. We did not, basically women who get infected, no matter they're pregnant or non-pregnant, they kind of have like a similar chance of like developing severity, like a severe situation. And also COVID-19 did not show that it can infect the baby. There's no strong data to support the vertical transmission. We don't know, but like a majority of the data actually coming from those pregnant women who's in second or third trimester, which means the exposure of the virus is kind of short between the diagnosis up to the delivery. But those viral testing from the placenta, from the amniotic fluid, from the baby's like a nasal swab did not suggest that there's a vertical transmission. But if you get infection in early pregnancy, for example, like before 12 weeks, we don't know whether this COVID-19 infection can cause increased miscarriage or can increase the chance of a congenital anomalies. I think data is still very limited. And for those women who want to get pregnant in this period of time, I think there's no guidelines say that you should not get pregnant. But one thing you should think about is in case if there's any emergency happen, especially like in first trimester, for example, if you had a miscarriage or ectopic pregnancy, do you have adequate resources? Like, for example, the hospital or your doctor who's taking care of you have adequate resources that can provide those like emergent procedure or surgery for you. I think those are like an important thing you want to think about.
Absolutely. So plan your pregnancy, make sure your doctor is going to see you, especially if you're a high-risk
patient.
Even especially if you've had a history of ectopic. It'd be important to reach out to your doctor ahead of time. Okay, here's a bunch of questions. Do you recommend taking maca or royal jelly pills? And if you do, are they safe?
I think like those are like safe. I think like I don't see like the data showing that it's dangerous.
I agree, and I don't necessarily. I have a special sauce, but maca and royal jelly is not part of my special sauce. I haven't been too impressed with how they work. Okay, we don't have progesterone pessaries in this country, but someone's asking, is progesterone and oil better than pessaries? I mean, I wish we had pessaries here. They have them, I think, in Australia. Is one country where I know that they have them, but I would say that, I don't have as much experience with pessaries. I don't know that you have. Have you used progesterone? No, but it would be awesome. It would be awesome if we did, so we didn't have to do the shots every night. Okay, how about this question? Is weight loss during an FET prep a good or a bad thing?
Okay, that's like a really good question. I think like there have been, first of all, the data is solid in terms of the negative impact of overweight or high BMI to the reproductive outcome, especially like a lower live birth rate, lower IVF successful rate, and a higher chance of miscarriage. However, whether losing weight can improve the reproductive outcome or not is still debatable. I think recently there are large sample, there are data coming from large sample that showing when those when this woman undergoing fertility treatment, They underwent a very strict diet, intensive physical exercise, and they actively trying to lose like 10% of their body weight. Actually, those treatments did not significantly improve the ultimate outcome, which is the live birth rate.
Right.
So I would say during the FET cycle, I probably would not recommend a very aggressive, trying to like lose weight in that short time frame. I probably would not recommend.
Right. Yeah, I mean, and it's so hard too. Those hormones make you feel like a crazy person, and they change how you see food, and they make you want to, eat everything in sight. So those things just mess you up. And so I tell patients, if you can maintain your weight while you're on these drugs, it's like you're losing weight. Okay. So how about this question? Should lining be a certain thickness for a fresh transfer to be more successful? What's your goal lining for fresh transfers?
I think like as long as it's like well, ideally we want to look for something like beyond 8 millimeter, but like 7 to 8 millimeter is pretty good.
Yeah.
And less than 7, then it's associated with lower chance of pregnancy.
Yeah.
But I think it depends on some women, no matter what medication you give to them, no matter how you try, their lining can get to like a 7, but not to go beyond 8. I think as long as they can reach 7 millimeter, and if that's the best that they can get, I'm okay with the transfer.
Yeah, I agree. Okay, here's another question. Is it normal to get cysts on your ovaries after an egg retrieval? And then is it safe to proceed in the next cycle with a frozen embryo transfer?
Okay, good question. It's actually very common to have a cyst like formed right after the retrieval cycle. Most of them are just like we call corpus luteum cyst. It will go away spontaneously in 1 month or 2. And I don't think that will significantly impact your next FET cycle, but I think it's better to go to the medicated cycle if you decide to do the embryo transfer right after the retrieval, just because sometimes that cyst can interfere with your ultrasound monitoring if you want to try the natural cycle, FET.
Okay, here's another question. I have 2 PGS normal embryos, 2. Should I transfer one or both?
Okay, good question. I think right now in our society, we all agree that we will transfer only one genetically normal embryo. The live birth rate, I mean, average is about 60 to 65%. And transfer to a genetically normal embryo would just like significantly increase your chance of twins. I know many people want twins, but like as physician, we truly think like one healthy baby, healthy mom is the ultimate goal.
Okay, so this person, best is yet to come IVF, she just listed her supplements for us. I'm taking a prenatal, folate, fish oil, DHA, CoQ10, calcium, magnesium, zinc combination. Is there anything else you can suggest that I should take? Is there anything else that you would tell her to take? That sounds pretty good to me.
Yeah, I would. I agree with you. I would not take anything else. I think those are good enough.
Okay. Can you use your own eggs with an AMH of 0.08? 0.08, yeah.
Well, I think if you have like a follicle can grow, definitely you can. I know some physicians will do natural cycle, like a retrieval, for women who has like a diminished ovarian reserve and has only one follicle growing each cycle. You can definitely use that. As I mentioned, age is eventually the determining factor of your chance and fertility. If you're young with a low MH level, I think it's still worth to try.
Yeah, great. So this is a good question. I'm curious to what you think. What do you think of reproductive immunology?
Okay, I think this is a gray zone. There's so much uncertainty and unknown things in this field. I think like the data is also very muddy. And it's just hard to do a good designed randomized controlled trial with so much like confounding factors in the like infertility or fertility treatment. Personally, I think if a patient does not have any immunological issues, for example, if they don't have like Hashimoto's, if they don't have lupus, then I do not offer them any medication related to immunology. I know some physicians, they provide medication or treatment for those people who has recurrent failed implantation. I think the data is not very solid. It doesn't mean that we should dismiss this treatment for sure, but I think ASRM does have a recommendation to kind of try to very precautiously, like when you counsel and offer these treatment to patients.
I agree. I'm with you. Okay. So I'm 35 years old and I'm going to give you my fertility indicators, my AMH, FSH, and follicle count. And I want you to tell me which one's the best predictor of fertility. Okay. AMH is 0.75, FSH is 9, and follicle count is 14.
And how old is she? I'm sorry.
35.
35. Okay. First of all, 35 is the best number I would pick. But in terms of those three, I think your follicle counts, probably I will go with that. And then, FSH can fluctuate significantly during the cycle. Same as the follicle counts as well. But, like an AMH level, if it's like a 0.7, but you have I would say follicle number 14 is a little bit higher than what I would expect with MH level 0.7.
Right.
So I would say probably repeat another ultrasound to see what your follicle count would be. But I think age actually is the most important thing to determine your fertility.
Brilliant. Okay, here's another question. I'm 33 years old. Almost 6 years ago, I donated one kidney to my mom. The surgeon did laparoscopy, but also did a mini laparotomy. So one big C-section cut in my bikini area. Could that have negatively impacted my fertility?
You know what? So to be honest with you, I'm not quite sure what the surgical field it will involve, for donating one kidney. But I think if the surgical field did not involve the pelvis, then the chance to have a pelvic adhesion disease, from those surgery, probably will be low.
Super low. Yeah, I agree. I think we're almost done with questions. We have one last question. Are you ready?
Okay.
Almost an hour of questions. I love this. You have to come back on. I don't know that we've gotten so many questions before. Okay. How effective is weekly acupuncture for IVF? How effective is it?
Okay. I think so when I saw the acupuncture in the US and acupuncture in China, it's actually very different. So in China, when I had acupuncture, it's very intensive, aggressive, let's say in that way. But I think in the US, most acupuncture treatment is much gentler and soft. I think it definitely can help some people to relax and to just mentally feel better. I don't think it's gonna hurt. In terms of how much help or improvement it can provide to your outcome, I think it's really hard to say. But I think if you feel acupuncture is helping you to relax or mentally making you feel less stressed, I think it's definitely go for it.
I want to hear more about the more aggressive Chinese acupuncture.
They have very long needle and just going into your muscle and twist it.
No.
Yeah.
Shut the door. Seriously? Oh, wow. I didn't know that. Are there any acupuncturists here to do it that way? The more aggressive
I don't think so. I think in the US, whatever, so far what I saw, I have been seeing is kind of much
gentler.
Less,
no, gentler. A lot of patients are going through enough of those shots. They don't need to have something piercing their muscle. Oh, that's amazing. Okay. Well, last question. Okay, we're going to close it off after this. I know, ouch. Okay, I noticed I had blood clots during my period after an egg retrieval. Do you think that's a complication from the egg retrieval?
I don't think so. Well, I cannot say for sure, but I mean, during the egg retrieval or stimulation cycle, let's say your estrogen level is much higher than usual, so your endometrial lining will be much thicker. That can cause heavier menses in that cycle. So I don't think that's truly the complication from the retrieval. I think it's just the effect of estrogen. And then your next cycle, when you go back to your normal natural cycle, it will go back to your usual state.
So what I tell patients is, I just want you to know that your period after an egg retrieval could look like a murder scene. Does that sound bad? That sounds really bad. That sounds so bad. But it's true,
That's
right?
true.
It's like
Yeah.
the heaviest, most painful period. But then I
True.
tell people, if you don't have that, it doesn't mean anything is wrong with you either. Like sometimes it's not horrible, but expect like the worst period of your life. Because if you don't tell people that, they freak out. And they like go to the emergency room, they call 911 because they think that something happened to them and you cut them. And I'm like, I didn't do anything, you know.
I need to consult my patient and provide that information from that.
Maybe not use the term murder scene. I'm sure there's something a little bit better than that. But after all, we use the word trigger shot every time when we talk about ovulation. So that's kind of silly. Oh, someone is saying I have endometriosis, so it's always like that. And I'm sorry. I'm going to do everything I can to help anyone out there who has endometriosis. So thank you. Okay. Jie, thank you for being on with me.
It's so
fun to talk to you. I appreciate it.
I'm so happy to be here with you.
Yeah,
it's so fun. Every time when I'm with you, I learn so much.
Oh no, we So will you come back again? Can we do this again another Friday?
Absolutely. Awesome. I'll be very happy to do that.
Awesome. Okay. Thank you, Jie. Have a great weekend.
Thank you.
See you soon.
You too.
Bye, guys.
See you.
Bye.
Bye.
Bye, everyone. Thanks for joining us. See you soon.
Thank you. Bye-bye.
Bye.